Okay, so this is part 2 of Neuroendocrine Basis of Common Reproductive Disorders, Pathophysiology and Diagnostic Evaluation. And here are my disclosures. So here we're going to talk again in a different manner about neuroendocrine physiology and function, and talk about diagnosing and managing patients with this condition. And these are some of the learning objectives that come from the American Board of OBGYN learning objectives for fellows in REI. And we just sort of reviewed that before, but just to catch everyone back up, we've got neuroendocrine cells in the hypothalamus, and they elaborate releasing hormones, CRH, TRH, GnRH, and then we think of these somatostatin as inhibiting, dopamine as inhibiting, and there may be an inhibiting factor here that we don't think about very much, and probably has been less well established than all these others, as also prolactin-releasing peptide. So under normal circumstances, you have CRH driving ACTH through pro-opiomelanocortin. You have TRH driving TSH and then driving the thyroid gland. You have LH and FSH driving the testes and the ovary. And you have prolactin subserving lactation, among other actions. And then you have growth hormone that is responsible for things like bone acquisition. And then you have the hormones themselves that are secreted. So we have glucocorticoids or corticosteroids from the adrenal, which sits on top of the kidney, thyroid hormones, which we've reviewed in part 1, testosterone, estradiol, and progesterone. And if we think back to part 1 and the patient with Sheehan syndrome, although we didn't measure that individual's prolactin, her prolactin was low, in addition to her oxytocin being low. And so that actually indicates that there was partial anterior pituitary damage. So if we had measured prolactin in someone and it was elevated, that would actually indicate that there was insufficient dopamine. So that could have gone either way for the woman with Sheehan syndrome. She could have either had high or low prolactin, depending on where the damage to the pituitary occurred, whether it occurred at the pituitary stalk level as shown here, in which case dopamine would not have been able to suppress lactotropes and they would have functioned autonomously, or it could be low if there is an insult to the anterior pituitary itself. So this is just showing some of the other actions down below. So prolactin has profound effects on the breast. It's not just lactation. TSH has lots of actions on every single tissue in the body. So we forget that the thyroidal axis is so critical all the time. And when we think about ACTH, we think about too much, but we need to remember also that you have to have enough. So there's adrenal excess, and there's adrenal insufficiency. And we know that growth hormone works through the liver to create insulin-like growth factors that are released and go throughout the body. And we know that there are many, many, many side effects and intended good effects of estradiol and progesterone on the phenotype of a woman and a man for estradiol. And then testosterone and other androgens obviously influence the phenotype of everybody. And so what we're talking about when we talk about phenotype or presentation is the health of this entire system and how it's functioning. So for the woman who had the Sheehan syndrome, if she was found to be deficient in cortisol, which she was, then the most important thing to do next for that individual is to actually replace cortisol. Because if the individual does not have cortisol sufficiency, it's far worse than having a little cortisol excess, and they can go into cardiovascular collapse. And it's important not to replace thyroid until you ensure that an individual has cortisol sufficiency. So that's the major take-home message, is that when one is confronted with a complex neuroendocrine condition, such as Sheehan's, that can be variable in presentation, one needs to think through all of these relationships before coming up with an action plan. And so this only shows the anterior pituitary, but one also has to be mindful of the posterior pituitary. And we did not talk about the posterior pituitary as it relates to stress, but stress has effects on it as well. So this entire neuroendocrine axis is fully responsive to life events, whatever those life events are. And it's fully responsive to cognitions and emotional valences. So via the cortex and the limbic lobe, we regulate internally our neuroendocrine axis. It's also fully responsive to day and night signals, which we haven't really talked about as well. But this very complicated system is meant to be highly responsive to environmental and internal factors in order to keep us healthy and alive. And so when we see a large magnitude stress response, it's meant to be short-lived to get the individual to a better place, to motivate the right kinds of actions and behaviors. But we know that some of the time the stress is unresolvable and you don't get appropriate responses. So we don't want the system to be anything other than functioning at a homeostatic level, but there can be chronic alterations, which we call allostasis, that have then chronic health consequences. And again, just to say, the hypothalamus is not one spot. It also has its zip codes, which are shown here, and each of these areas regulates different kinds of neuronal pathways that then eventually feed on the pituitary in some manner. So it's sort of beyond the scope of today to go through all those complexities, but I think it's fair to say as a bottom line statement that the brain has access to the system, and it's through the cognitions and emotions that the system is actually activated or inhibited. Now, you didn't mention just briefly that time of day signaling matters to the neuroendocrine axis. And what I've shown here is the pineal gland. And it is a funny little body part shown here, which I think many of us were taught in medical school was vestigial and served as an excellent midline marker for the neuroradiologist if it was calcified. So that's sort of undermining its importance because it really is the part of the body that secretes a hormone called melatonin that actually makes all those neuroendocrine relationships that we just discussed have a circadian pattern. So it is melatonin that synchronizes cortisol and thyroid and other neuroendocrine signaling systems to control appetite and metabolism and sleep. So the entire endocrine responses to day and night are coordinated through the pineal gland secretion of melatonin. One of the learning objectives is to understand sexually dimorphic nuclei, and that's kind of a challenge. And I wanted to just sort of paint a broad picture for understanding that. So you saw in the last diagram the fornix, and that's part of the limbic lobe. And you can see that it has importance for the hypothalamus, as shown here. But the limbic lobe is actually more than that, and it's a lot of different, what we call cingulate gyrus brain functions. And the non-reproductive brain functions that are modulated by sex steroids are shown here. That includes mood, sleep, libido, sexuality, social behavior, cognition, which is speed of processing primarily, motor coordination, neuroprotection. We won't have time to go through all of that now. Epilepsy threshold, pain thresholds, and auditory thresholds. So it does turn out to be true that androgens actually raise the auditory threshold and make men and women who take them less responsive to low-level ambient noise. This is something to think about. And we know that the mechanisms by which sex steroids impact the CNS are multiple and are shown here. So not only does the fetal brain get organized in utero by the hormones to which it is exposed, once puberty occurs, there are activational influences of the same hormones, and they activate different neuronal tracts in men and women. And there is a lot of receptor subtype crosstalk, as we've talked about, and steroids actually play a role in modifying that crosstalk. We know that sex steroids actually control neuronal cell death and apoptosis. They actually control synaptic density and inflammation and blood flow. So that's a giant amount of information. And we know that the brain itself is sexually dimorphic. So forget the little subparts, but actually the brain itself is dimorphic in a fairly major way. And what you can see is a cartoon, really, of the areas that are larger in females shown in red, and the areas that are larger in males shown in blue. And so we have some core concepts that have evolved over the last 20 years. One is hormone-dependent sexual differentiation of the brain. So just talked a little bit about that. That mostly occurs in utero, but not completely. And there's more hormone-dependent sexual differentiation at the time of puberty. There's hormone-independent sexual differentiation that has to do with genotype. And then there's sex-specific hormone action. And some of that's going to be a little beyond where we are in this lecture today, but in terms of understanding the complexity that the brain sees, remember that a neuron that has an XX genotype will respond to testosterone differently than a neuron that has an XY genotype. So that's what we call sex-specific hormone action. Testosterone will have one set of effects on the brain of a female and perhaps different effects on the brain of a male based on genetics. We also know that even though the same brain parts exist in men and women, they don't always function in the same way. And this was a really fun study by Larry Cahill's group some years ago. So men and women are read a story, and then they're asked to report what they heard. And so the interviewer says, what was the bottom line? How did you reach this conclusion? And what's the take-home message? So here you can see that men are hearing the story predominantly. You can see the yellow is activation, predominantly with this part of the body. This is the amygdala. So it's generally silent on the left side in men hearing the story and generally activated on the right side. And strangely, the opposite pattern for women. So what does this really mean? Well, when they ask people what they heard, generally speaking, men remembered a lot of the details, but sometimes weren't sure what the story meant. And women generally tended to get the gist of the story, but often couldn't remember how they got to that conclusion. So one of the conclusions is that women and men process information differently. And another possible conclusion is that if you really want to get the best picture of what's going on, you need to have both men and women hear the same story, because they're going to hear it in a different way. And I always think about this when I'm giving a talk, because I know that I have some of everybody in an audience, and they're hearing the same information in different ways. And not all of it's just sex differences. Some of it's just individual past experience with the information, what you're interested in. But I just think it's important to remember that when we are in an educational environment and we think we've delivered a crystal clear explanation of something, that not everyone will have heard it in exactly the same way, nor will they be able to repeat what you said in exactly the same way. So there will be a range of remembrances and interpretations, if only because our brains are processing the information in different ways, and in part that is sex related. So this is another fascinating sort of understanding of sex differences. And there's more information from this study, but this is just an introduction to the concept. So what you see is a study that was done by putting people in a neuroimaging environment and then putting in the neuroimaging tube aerosolized hormones. And these hormones are known as pheromones. And so in men, testosterone is aerosolized into something called AND, and that's not its full name, but that's what we're using it to call it here, versus air. And then females aerosolize a version of estradiol that's been modified so it can actually be aerosolized. So it comes off the body and floats in the environment, and that's what we think a pheromone is. So you're not consciously smelling this, you're just in an environment where there are these pheromones. All of us are every day in an environment where there are pheromones from other people. And what you can see here is a female brain exposed to the male pheromone and these are the parts of the brain that are activated. And just to reinforce, the person probably has no concept that their brain is being activated in this region that they can articulate. And this is a male brain, and these are heterosexual females and males. So this is a heterosexual male brain exposed to female pheromone. Again, it's very unlikely that the individual will be able to articulate this activation in a meaningful way cognitively. And then this is a female brain exposed to female pheromones. And this is the brain center that's activated. This is actually the amygdala, and the amygdala mediates fear and aggression. So I will leave the listeners to decide what that might mean. But if you had to have an environment in which everyone lives closely, and now I'm thinking of like a dorm or something, it's interesting to think that female pheromones might be perceived by females as irritants. And then this is the male brain exposed to male pheromones. And at least in heterosexual men, there's actually no activity that results. So males are not able to appreciate each other's pheromones. They're not aware of them. So they're sort of inactive to one another or neutral to one another. So there are some potentially profound consequences of these activations, in part because they are more or less subconscious, and people are not always aware of these activations in a way that is clear for them to articulate. Sex steroids influence all neurotransmitters, so not just pheromones and so forth. And so that's just a partial list, but we know that sex steroids modify GABA, for instance, and we've just reviewed a little about what GABA does. But it's important to think that when GABA sees a lot of testosterone, whether you're a female or a male, that it might actually function in a different way. And GABA is a very, very important neurotransmitter for the brain. It's got mostly inhibitory effects, but it's got stimulatory effects as well, depending on the brain area. And it's one of the most abundant neurotransmitters around. So to think that it is actually interacting with the sex steroid milieu is important in a lot of little clinical areas, including understanding regulation of the gonadal function, but also in terms of understanding appetite, understanding seizure thresholds. And so there's a lot of different clinical domains in which this information is relevant. The one that I think's received a lot of attention is menopause, and whether or not postmenopausal hormones actually play a role in maintaining brain function. And based on what we know now, it would appear that estradiol is important for maintaining all of these neurotransmitters functions and the cell bodies themselves. So in fact, testosterone has many of its CNS effects by being aromatized to estradiol. And men and women actually have, roughly speaking, the same amount of estradiol in their CSF, which is sort of interesting in and of itself. So men have a higher T to E ratio, but women and men have similar estradiol levels, bathing these neurotransmitter systems. And maybe that's important because synapses are actually maintained, it would appear, by estradiol. And this is just a diagram of a synapse so that we appreciate that it is a highly energy requiring part of the brain. And lots of signaling systems interact at the synapse level, allowing neurons to communicate in very specific ways. These neurons here are hippocampal neurons. So they are the ones that mediate memory, and it's been suggested that mild Alzheimer's occurs when there are about 25% of these synapses that are lost. And aging itself causes synaptic loss, particularly in the dentate gyrate of the hippocampus, but we also know sex steroids play a role, and I'm going to review that now. So there was a study done in which young and old Rhesus monkeys were ovariectomized, and after 3 months, either given vehicle or estradiol for 3 weeks. And then dendritic spine density was counted, so that is actually synaptic density in both the young and the old monkeys. And here's a sort of a picture of what was found. So brain A is synaptic density, and you can see that there's some wide open spaces between these dark spots. And this is a female brain after 3 weeks of estradiol, and it's a lot more intense in terms of black. And so we think this is an increase in synaptic density, and that's shown here. So it would seem that estradiol is really important for maintaining brain architecture and brain connectivity. And in fact, that's what some of the neuroimaging studies suggest as well. So we talked a little bit about 18. We're going to talk some more because I think this is complicated enough that we have to reinforce it on a pretty regular basis. So I think it's time for a case presentation. So a 27-year-old woman presents with a chief complaint of secondary amenorrhea and urinary HCG is negative. What next? So what's the most likely diagnosis? Functional hypothalamic amenorrhea, hypothyroidism, polycystic ovary syndrome, pituitary tumor, or premature ovarian failure. And I bet the answer FHA would not be everyone's first choice. And depending on what data you look at, that might well be the right answer. So this is data from our ASRM executive director who's just recently retired or is about to retire, Richard Reindaler, and looking at causes of amenorrhea. This is years ago, but it's still a great study. And it shows, depending on how you want to look at this, that functional hypothalamic amenorrhea is the #1 cause of amenorrhea. So I think you have to hear it from the cause of amenorrhea, not the cause of anovulation. But I just thought this was very fascinating because some of the things that we sort of talk about, like hyperprolactinemia and premature menopause, are in fact less common than one would think as causes. And this may have shifted a little, but I think, you know, it's primarily that the two most common causes of amenorrhea are going to now still be sort of what I would say is hypothalamic hypogonadism due to stress versus hyperandrogenism and PCOS. But I would argue that some people in this category actually have stress as well, so I'm still looking through the lens of hypogonadism as a primary cause of anovulation and amenorrhea. And when you encounter a person with amenorrhea, you really have to break it into levels. So this is in fact anatomic levels, and it's easiest to start at the vaginal level and work your way up in terms of trying to think of the differential diagnosis. And there are ways to approach looking for the different disorders that might cause amenorrhea, but by and large we end up having to do lab work and understanding what the labs mean. So imaging might be important, a physical exam is always important, but we can't make very good diagnoses without resorting to laboratory testing. And I do think that people are hesitant sometimes to do that, but remember that functional hypothalamic hypogonadism, so-called stress-induced anovulation / amenorrhea, is really a diagnosis of exclusion. You really have to make sure there's no other cause. And there can be a tendency to assume it's stress, but stress has to be proved, and you can't really always prove it by asking somebody. So the proof of stress actually is cortisol, and measuring cortisol at night in individuals is not easy. So it is difficult to prove what level of stress or what level of HPA activation an individual is experiencing. Can get some hints about that, but it's really difficult also to ask people if they are stressed, because most people will not actually be aware of all of their neuroendocrine functioning in an articulate way. So what we found is that people who have had high cortisol levels didn't always report high stress levels to us. And so that is why just asking doesn't always get you where you want to go in terms of understanding what's going on. So we also have to remember that there are genetic causes of hypothalamic hypogonadism, and this is a paper from 2011, and there are many more causes that have been reported since. But there's a gene-rich receptor gene defect. There's CAL1 and ProKR2, which is a receptor gene defect or variant. There's fibroblastic growth factor receptor 1 that shows a variant. And then this is the kisspeptin receptor, which makes sense based on what we reviewed earlier and so forth. So you have all of these different possibilities in terms of health of the GnRH pulse generator that actually determine in part sensitivity to stress and the phenotype. So even with organic forms, not everyone is fully amenorrheic, and not everyone fails to go through menarche and pubarche. And so we don't have a panel that we can send out really rather easily right now. But there's, a couple of different groups that are still working on trying to identify these genes that specify GnRH location and function. And we know that if the GnRH pulse generator isn't up to full function, we will not get full gonadal function. So how do you know if it's not up to full function? So in this particular person, let's just say the estradiol was under 40, the progesterone was under 1 nanogram per ml, and the LH was less than FSH. That speaks to hypothalamic hypogonadism. And if the same hormone levels showed a LH 3 times larger than FSH, that would speak to another cause, such as polycystic ovary syndrome. You'd still have to go through trying to decide between the two, because those two causes are the most common causes of anovulation and amenorrhea. So it's important to get it right because it specifies what you're going to do next. And you can't really derive what the gene or age pulse frequency or amplitude is from a single sample of LH, but you can make a decent guess with the LH-FSH ratio. And under chronic stress, the reason you get FSH higher than LH is in part because FSH and LH are regulated differently at the level of the pituitary. So not the hypothalamus, but the level of the pituitary, such that low estradiol levels favor an increase in FSH. And some people call this a return to pubertal pattern, but I think it really mostly reflects a chronic reduction in estradiol exposure, and so therefore FSH floats higher. And some of the forms of FSH that are released are bioinactive, so it doesn't really tell you that they're about to generate a follicle. It really means that LH is very low. And so that's the important take-home point on that one. If prolactin is low and there's a normal TSH, that fits with the pattern of stress that we've talked about. If you happen to get a T3 or T4, you might be able to capture the hypothalamic hypothyroidism better. Free T4 is least likely to show that to you because it tends to be normal under almost all circumstances. If you see relatively low androgens such as androstenedione and testosterone, then you really are headed in the direction of stress. And sometimes one might want to just actually measure cortisol. And the easiest way to do that actually is an overnight cortisol or 24-hour urinary free cortisol. And occasionally one would need to do some kind of neuroimaging or genetic studies. So depending on the diagnosis, but I'm tilting this in favor of functional hypothalamic amenorrhea. But you do have to look for outflow tract anomalies and abnormalities, including Sheehan syndrome. So there are ways to look for that as well. And I think the physical exam is, of course, always where you start, and then you have to go from there. But let's just say this patient had amenorrhea, but you were able to have a progesterone of 10 captured in your blood work, and then she still never had another period, then you know that you have to look at the level of the pelvic anatomy to make sure that you've got a responsive uterus, because if you've got a progesterone greater than 10, you've got a responsive ovary. And so that kind of stepwise thinking is really critical when you've got a woman with amenorrhea, and you have to get it right in order to do the right treatment. So just diagrammed here are some of the steps that one would take if you didn't find normal pelvic anatomy and things to consider. So chromosomal studies come into play when you think you've got a uterine anomaly, and you need to look for both the possibility of XX and XY genotype, and to think about testing for androgen receptor insensitivity syndrome. So that would start with a karyotype and 5-alpha reductase deficiency. So if you've got someone with ambiguous genitalia, or you've got someone who thinks they're female but they don't have pelvic organs, and you've got a 46XY genotype, then you are really heading in a different direction. And you've got, testicular feminization, most likely. Internal genitalia will be female if MAS and AMH were not elaborated during embryogenesis, and it's important to understand that point for understanding what's often termed Swyer syndrome. And of course, you've got XO and XO-XX mosaics to think about, as well as differential diagnosis of Noonan syndrome, which is a different deletion of the part of the X chromosome. And individuals with XX or mosaic genetic dysgenesis need to be tested for the Y remnant, because if they do have a gonad, it needs to be removed after puberty because of the risk in the gonadoblastoma. So all of this is not so much neuroendocrinology as some of the other things that we've talked about, but one has to be able to do all of this in order to get to the neuroendocrinology side of the house. So you really do have to rule out all the other options. And in particular, make sure you've got an intact outflow tract and don't have Asherman syndrome. So I think hypothalamic amenorrhea is just a wonderful example of needing to know everything in order to get to the right example. So you need to be able to do an excellent physical exam. You need to know what laboratory studies to order, and you need to be able to decide if radiologic imaging is necessary. And you need to be able to generate a full list of the differential diagnosis. So that's a tall order. It requires a lot of thinking, and I think that it's very important for what you're going to do next with an individual. And so we know if the cause is probably PCOS. We have some very good interventions in terms of ovulation induction if that's needed. We know, though, that we have to think about the concomitants such as insulin resistance, and we need to understand the full spectrum of hyperandrogenism in order to do a good job of ovulation induction and fertility promotion. And there are lots of conditions, actually, that mimic PCOS, and I think sometimes not appreciated. So, obviously, exogenous androgen use. Diabetes can look like PCOS, but it can actually, if you have a really sort of severe form of diabetes, it actually slows the gene-rich pulse generator. And otherwise, you've got increase in insulin, you get a PCOS-like picture, and it may be a concomitant of PCOS. But it's important to think about CAH, and we really don't tend to think about that unless 17-hydroxyprogesterone is greater than 3 nanograms per ml. I've had the good fortune of finding a couple of ovarian androgen secreting tumors in my career, and that is always a difficult cascade that one has to engage in to do this. But it does require measuring androgens, and sometimes I think we forget to do that. And in the case of finding the last one that I found, which was adrenal rest cell tumor in the pelvis, so immediately adjacent to the ovary, really that was hinted at by having normal androstenedione but markedly elevated testosterone. Cushing's syndrome can cause amenorrhea, either the syndrome itself or the disease. Acromegaly can cause amenorrhea, as can hyperprolactinemia, hypothyroidism, and hyperthyroidism. And these can all be concomitants with FHA, because there's no rule really that you can't have these as concomitants. And so we need to be mindful of the condition of autoimmune thyroiditis as well. And premature menopause can present with a variety of pictures, including amenorrhea, but also oligomenorrhea. And we can do a good job now of testing for this and looking for AMH levels to kind of tilt us in the right direction. I've talked about stress-induced and obesity-related anovulation. So stress can cause people to overeat. Overeating can itself have effects on ovarian function, and so you can actually get a sort of a two-hit scenario that looks like PCOS, because when you get obese, you can get plethoric, and you can get a phenotype that may be misconstrued to be PCOS. And then I think, again, anytime you've got amenorrhea or anovulation, even though it might be in the package of obesity and hirsutism, you have to remember that it could still be either functional or organic causes that are hypothalamic. So what is PCOS? Well, now we see two of our favorite neurotransmitters up there at the top, and we've got hormones, insulin, and androgens regulating those, and the ovary being kind of subjected to an increase in gene-rich LH pulse frequency, not a decrease. And I briefly mentioned that higher pulse frequencies in women of gene-rich actually lead to a decrease in FSH. So the faster the pulse frequency in PCOS, the more likely that it is to make it difficult to increase FSH. And while we tend to use letrozole and clomiphene to do that, and they act at the level of the pituitary to increase FSH, neither of those hormones actually alter GnRH pulse frequency and will not typically alter LH itself. So I tend to think of these two conditions, PCOS and FHA, as dichotomized. And while it might be difficult to convince you of this, it's possible that women with PCOS are more stress resistant than otherwise eumenoric women. And that's a story for another day. But I do think they are less reactive to certain psychophysiologic stressors, and that weight sometimes buffers people from stress, particularly if we're talking about metabolic leukopenia. So if you've got a stress that causes leukopenia, and the leukopenia amplifies the stressor, you're probably unlikely to find that kind of scenario so often in women with PCOS. And then, of course, understanding the evolving world of premature ovarian insufficiency, diminished ovarian reserve / perimenopause is always a challenge, because there are many genetic causes that have now been identified for low AMH. And we poorly appreciate, I think, what happens as we get reduced egg count. And so this is actually looking at age-related decrease in egg count down here and the ensuing hormonal patterns that accompany folliculogenesis, as shown by Nanette Santoro. And what you can see is this is the LH surge as the anchor, and it's a shorter follicular phase in perimenopausal women, higher FSH levels. Even though they are ovulatory, their progesterone levels are lower, and the estradiol levels are higher. So the increase in estrogen levels, this is urinary, so it's E1 glucuronide, but it's actually a reflection of estradiol, and this is pregnant diol glucuronide, which is a reflection of progesterone. If this were just simply two follicles, you'd expect a much higher progesterone level. So this is very likely a dysfunctional follicle that makes too much estrogen and too little progesterone. And what's really fascinating, honestly, is that the FSH signal to initiate folliculogenesis actually starts in the luteal phase in women who are perimenopausal. And this may well explain the missing front part of this, so that they have a shorter follicular phase that you can appreciate, and instead of one follicle developing and stopping and one follicle developing and stopping in a sequential manner, you may actually get an overlap of folliculogenesis such that one follicle has yet to die from a preceding menstrual cycle and another follicle is already out of the gate. So what can you do for any and all of these? Well, there's a range of hormone solutions and a range of fertility solutions, and this is just a partial list of hormone solutions. If you really think that diagnosis is FHA, SIA, you need to remember that they may not experience withdrawal bleeding when given continuous birth control pills and or cyclic birth control pills, whereas cycle control is really important for women with PCOS to prevent endometrial hyperplasia. And you can use birth control pills and other hormones for perimenopausal women, but you need to be mindful of screening for conditions. If they have underlying autoimmunity or so forth, you might need to reflect on which hormones would be safest in this category. And if they need birth control versus cycle control, then there's a range of hormone interventions that need to be thought about. So generally, hormonal contraception is safe for women with PCOS. But if they have really high triglycerides, you need to remember that ethinyl estradiol passing through the liver will increase that. On the other hand, continuous use of ovarian suppression with hormonal contraception may in fact actually slow or reverse phenotypic and biochemical features of PCOS. And typically in adolescence, this is what we want. And bone effects often need to be considered. So in women with hypothalamic amenorrhea, and low estrogen levels on a chronic basis, there will not be full bone accretion. And to make matters worse, cortisol interferes with estrogen action on the bone. And the bone, to be fully able to respond to hormones such as estrogen, has to be eumetabolic and can't be in a catabolic state. So if your thyroid hormones are hypothalamic hypothyroidism, you're not going to be able to build bone normally, even when exposed to the right amounts of hormones such as estrogens and progestins. And women with PCOS typically have excellent bone density because of the mild hyperandrogenism. And perimenopausal women, if they've gone for a while without having fully ovulatory cycles, may well respond to E2 plus P of many different kinds, progestin preparations. But if they really actually had pretty decent hormone exposure during the perimenopause, they may be fine in terms of bone density. Somewhat underappreciated is the mood effects of progesterone and progestins, and I don't think those two lead to the same mood effects, but that is an area that hasn't been well investigated. One always needs to be mindful of DSM diagnosable disorders, and particularly in women with FHA and SIA. So there is no rule that depression won't present as FHA or an eating disorder won't present as FHA. And there also may be drug use as a cause for FHA, and we didn't talk much about that, but with the opioid crisis on our hands, it's true that opioids depress GnRH function, both in men and women, so you may get a drug-induced FHA. We don't know much about progestins on the mood states of women with PCOS, but there are some studies suggesting that women with PCOS are also more prone to not really stress, but depression, and we're not really sure what the cause of that might be. And then perimenopausal women often have mood swings associated with the undulating higher excursions of hormones that are seen with estrogens, estradiol, in the perimenopause. And of course, as you enter the perimenopause and go through the perimenopause, the estradiol surges, if you will, become more dramatic, and the drops also more dramatic. So let's review the case. This is the 27-year-old woman who presents with amenorrhea. She's recently married and wants to conceive. She's a corporate lawyer and travels frequently. She reports normal developmental milestones, menarche at age 13, regular menses until 1 year ago, and she took oral contraceptives from 18 to 25. So we really don't know what her menstrual cyclicity pattern was, and she's now been amenorrheic for 8 months. And her BMI is 21. Visual fields are normal. Thyroid appears unremarkable. She's Tanner stage 5. Habitus is gynecoid. There's nothing to suggest Cushing, such as stria or areas of hypopigmentation, and hair distribution is normal. So what labs would you like to order to confirm your initial impression? So here are some labs from a real person, and it's just what we talked about previously. So her LH is 4, her FSH is just a tad bit higher than that. Estradiol and progesterone are low. Beta is negative, prolactin is on the low side, TSH is on the lowish side, and interesting, total thyroxine is really low. So that sort of speaks to hypothalamic hypothyroidism, particularly since the TPO antibody is negative. Celiac screen is negative, and head MRI is negative. And why did I put celiac screen in there? Because nutritional deficiencies lead to FHA, and celiac disease is pretty common. About 1% of people who have what I would say no symptoms that are easily appreciated, they probably do have symptoms, actually have celiac disease as a cause of undernutrition. And so that might sound a little high, but we're still in the sort of, I think, the defining stages of understanding how common celiac disease is. But I screen all women with hypothalamic amenorrhea for it because it's a bad one to miss, and there's a lot you can do if you make the diagnosis. Assuming that you think she has SHA, what would you like to do next? Would you like to refer her for counseling? Would you like to give her clomiphene citrate? Or perhaps controlled ovarian hyperstimulation with gonadotropins? Or why not go right straight to IVF? Well, we talked about that before, and I think, everyone might come at this from a different perspective. Recently, we made a position paper at the Endocrine Society level, so it's guidelines for the treatment of hypothalamic amenorrhea. And just for brevity's sake, I didn't put all of that in here today, but I think I would refer you to that to go through this cascade and make up your own mind. But I will just say a few comments about each of these options. So clomiphene citrate or letrozole may not work if the hypothalamus is already insensitive to low estradiol. So what we think is going on with FHA is that the hypothalamus is either insensitive or overly sensitive to low levels of estradiol. So if it's insensitive, it's not going to matter if you drop the estradiol level with clomiphene or letrozole. FSH is not going to be able to really rise very much, and it won't be able to rise typically to the sufficient level to allow for full folliculogenesis. So when someone is, quote unquote, clomiphene resistant, it's important to think about whether they actually have some form of stress-induced anovulation, rather than to think that they have some more difficult features of PCOS and proceed, for instance, to ovarian drilling. So, other hormone levels like AMH may be helpful in this regard in helping you decide what kind of picture you're dealing with. But our data suggests that even women with PCOS can get FHA, and infertility is a very good stressor for most people. So I think the astute clinician really has to think about why someone wouldn't respond to clomiphene, and to remember that it might be a mixed picture, and or it might be an unrecognized stress-induced anovulation. So the next is controlled ovarian hyperstimulation with gonadotropins. I think we all know the risks there, particularly if the AMH is good to high. And while it's done and it results in pregnancy, it tends typically to result in more multiparity than most people would tolerate. In vitro fertilization probably will work for women with stress-induced anovulation and functional hypothalamic amenorrhea. However, stress does play upon the endometrium and prevents estrogen action. And it's possible that some of what we see in terms of implantational deficits actually represents stress. We recently wrote a chapter about this. And I think that it's important to remember that, and I didn't put all the data in for this, but that actually cortisol literally hijacks the cellular machinery that's needed for estrogen action. So there is no reason not to do A for anyone that you think would benefit from it. And you can do A coupled with any of these others and probably get a better effect. So I'm going to leave it with that somewhat controversial statement just to get you thinking. And I hope that I've contributed to a more nuanced understanding of how the hypothalamus plays a role in many of the infertility presentations that we see in our office every day. And I thank you for your attention. It's been a pleasure.